Bismillahirrahmanirrahim. The quote of the day is magic is believing in yourself. If you can make that happen, you can make anything happen. The topic of today's presentation is breastfeeding, baby-friendly hospital initiative and kangaroo mother care under the supervision of Professor Dr. Saira Afzal. The learning outlines of today's presentation is the 10 steps of baby-friendly hospital initiative, kangaroo mother care, exclusive breastfeeding, breastfeeding techniques and their advantages. By the end of this presentation, participants will be able to describe kangaroo mother care and its benefits, 10 steps of baby-friendly hospital initiative, breastfeeding techniques, positions, protocols, and its benefits. Now, first of all is baby-friendly hospital initiative. It is established in 1991 jointly by the WHO and UNICEF in response to the 1990 Innocenti Declaration on the promotion, protection, and support of breastfeeding. The aims of Baby-Friendly Hospital Initiative are to provide health facilities with the framework for addressing practices which have a negative impact on breastfeeding. To achieve breastfeeding health initiative accreditation, health facilities must demonstrate a rate at least 75% exclusive breastfeeding among mothers at discharge, adherence to the International Code of Marketing of Breast Milk Substitutes, successful implementation of 10 steps to successful breastfeeding. Know the 10 steps of successful breastfeeding. Number 1 has two components. Number A is have a written breastfeeding policy that is routinely communicated to all healthcare staff and comply fully with the International Code of Marketing of Breast Milk Substitutes and relevant World Health Assembly resolutions. Point 2 is train all healthcare staff in skills necessary to implement this policy and to inform all the pregnant women about the benefits and amendments of breastfeeding. The fourth point is to help mothers initiate breastfeeding within an half of hour of birth. Number 5 point is show mothers how to breastfeed and how to maintain lactation even if they should be separated from their infants. Number 6 point is give newborn infants no food or drink other than breast milk unless medically indicated, and practice rooming in, that is to allow mothers and infants to remain together for 24 hours a day. Point 8 is to encourage breastfeeding on demand. Give no artificial teats or pacifiers to breastfeeding infants. And number 10 point is foster the establishment of breastfeeding support groups and refer mothers to them on discharge from the hospital or clinic. Now the poster of the 10 steps of successful breastfeeding. The number 1 point that is the hospital policies that are not promoting infant formula bottles or teats, making breastfeeding care standard practice, keeping track of support for breastfeeding. The second point that is staff competency, that is the training staff of all the staff of the hospitals on supporting and mothers to breastfeed and assessing healthcare workers on their knowledge and skills. The number third point that is the antenatal care, in which the hospitals support mothers to breastfeed by discuss the importance of breastfeeding for babies and mothers and preparing preparing women in how to feed their baby. Number 4 point that is care right after birth. Encourage skin to skin contact between mother and baby soon after birth, helping mothers to put their baby to the breast right away. Number 5 point that is support mothers with breastfeeding. That is the checking position, attachment and sucking, and giving practical breastfeeding support, helping mothers with common breastfeeding problems. Number 6 point is supplementing. That is the hospital support mothers to breastfeed by giving only breast milk unless there are medically reasons, prioritizing donor human milk when a supplement is needed, helping mothers who want to formula feed to do so safely. Number 7 point that is rooming in, letting mothers and babies stay together day and night, making sure that mothers of sick babies can stay near their baby all the day. Responsive feeding, helping mothers know when their baby is hungry and not limiting breastfeeding times. Number 9 point is that is the use of bottle teats and pacifiers. Counsel mothers on the use and risk of bottle feeding teats and pacifiers. And number 10 point is the discharge, referring mothers to community resources for breastfeeding support, working with the communities to improve breastfeeding services. Since baby-friendly hospital initiative began, More than 152 countries around the world have implemented the initiative. Baby-friendly hospital initiative promotes a multi-level, multi-sector approach which, together with legislation regarding statutory maternity leave and protection of the breastfeeding rights of women in workplace. Enforcement of the code of the marketing of breast milk substitutes is essential to effectively promote, protect, and support breastfeeding. Monitoring and reassessment of baby-friendly hospital initiative facilities are important as the initiative expands. Now the benefits of baby-friendly hospital initiative. Baby-friendly hospital initiative has been shown to be very effective in increasing breastfeeding initiation, exclusive breastfeeding duration in many countries, improving mothers' health care experiences, reducing rates of infant abandonment. Re-evaluation of breastfeeding health initiative. In 2015, WHO and UNICEF began a process to re-evaluate and reinvigorate the BFHI program, a WHO guideline protecting, promoting, and supporting breastfeeding in facilities providing maternity and newborn services was published in 2017 based on a careful examination of evidence for each of the 10 steps. An updated implementation guidance for countries implementing the baby-friendly hospital initiative was published in 2018. The countries that are called upon to fulfill 9 key responsibilities through our national baby-friendly hospital initiative programs are establish or strengthen our national breastfeeding coordination body, integrate the 10 steps into relevant national policy documents and professional standards of care, ensure the competency of health professionals and managers in implementation of 10 steps, utilize external assessment systems to regularly evaluate adherence to the 10 steps, development and implement incentives for compliance and or sanctions for non-compliance with 10 steps, provide technical assistance to facilities that are making changes to adopt the 10 steps, monitor implementation of the initiative, advocate for the baby-friendly hospital initiative to relevant audience, identify and allocate sufficient resources to ensure the ongoing funding of the initiative. Now, this is an article that is published in Lahore, Pakistan. That is the title of the article is Implementation of Baby Friendly Hospital Initiative in Various Private and Public Hospitals of Lahore. The aim of the article is to determine the implementation of 10 steps of Baby Friendly Hospital Initiative in randomly selected private and public hospital clinics of Lahore. The method used is cross-section study and it is from multiple health sector from April to July 2017. The results included are it is observed in this study that 60.8% of baby-friendly hospital guidelines are being observed and implemented in various hospitals of Lahore. The conclusions are that the maternity care practices in hospitals or clinics of Lahore are not completely being carried out according to the 10 steps for successful breastfeeding for maternal and child well-being due to the lack of resources, inadequate training of health staff, and high patient load are the key hurdles in the implementation of these steps. Now, the revival of nationwide baby-friendly hospital initiative urged. This is a seminar that is conducted in Aga Khan University, Karachi at 8th of August 2020. In Pakistan, in this seminar, it is discussed that in Pakistan, breastfeeding rates are still low according to the National Nutrition Survey of 2018. The promotion of children put to breastfeed within 1 hour after delivery was only 45.8% and exclusive breastfeeding was 48.4%. Now the introduction to the breastfeeding. Breastfeeding is the feeding of an infant or young child with breast milk directly from the female breast or via lactation. It is a normal way of providing young infants with the nutrients they need for healthy growth and development. Anatomy and physiology of the human breast. The breast consists of glandular tissue and supporting tissue and fat. Milk is secreted by the glands and travels through the tubules which drain into the lactiferous sinuses. The sinuses which store small quantities of milk lie below the areola. They open out onto the nipple through the lactiferous ducts. The thin layer of muscle myoepithelium surrounds each gland. The contraction of these muscles causes ejection of milk from the glands. This is the structure of the human breast. Now the milk production and secretion. Milk is produced as a result of the interaction between hormones and reflexes. During pregnancy, the glandular tissue is stimulated to produce milk due to various hormonal influences. Two reflexes mediated by two different hormones come into play during lactation. The first one is the prolactin reflex. Prolactin is produced by the anterior pituitary gland, which is responsible for milk secretion by the mammary gland cells. When the baby sucks, the nerve endings in the nipple carry messages to the anterior pituitary, which in turn releases prolactin. The earlier the baby is put on the breast, the sooner the reflex is initiated. The more the baby sucks at the breast, the greater is the stimulus for the milk production. The greater is the demand for milk, the larger is the volume for milk produced. Now this is the prolactin reflex. When the baby is sucked, the reflexes are sent to the anterior pituitary, and from there prolactin is released, and which causes the secretion of the breast milk. Now the second one is the oxytocin reflex. Oxytocin is the hormone produced by the posterior pituitary. It is responsible for contraction of the myoepithelial cells around the glands, leading to the ejection of milk from the glands into the lacteal sinuses and the lacteal ducts. This hormone is produced in response to stimulation to the nerve endings in the nipple by suckling, as well as by the thought, sight, or sound of the baby. This is the oxytocin reflex. When the baby sucks, the impulses are carried to the posterior pituitary, and oxytocin is released in blood and carried to the breast, which causes the ejection of milk from the breast. When the infant sucks at the breast, stimulation of nerve endings in mother's nipple or areola sends signal to the mother hypothalamus or pituitary. Pituitary releases prolactin and oxytocin. Hormones travel via bloodstream to mammary gland to stimulate milk production and milk ejection. That is called the let-down reflex. Know the reflexes in the baby. The baby's reflexes are important for appropriate breastfeeding. There are three reflexes. Number one is the rooting reflex. When something touches a baby's lips or cheek, the baby turns to find the stimulus and opens his or her mouth, putting his or her tongue down the and forward. It is present from about the 32nd week of pregnancy. The second one is the sucking reflex. When something touches a baby's palate, he or she starts to suck it. The number third is the swallowing reflex. When the baby's mouth fills with milk, he or she swallows. Preterm infants can grasp the nipple from about 28 weeks of gestation. They can suckle and remove some milk from the breast at about 31 weeks of gestation. Coordination of suckling, swallowing, and breathing appears between 32 and 35 weeks of pregnancy. A majority of infants can breastfeed fully at a gestational age of 36 weeks. Now the types of breast milk. The types of breast milk are colostrum, transitional milk, mature milk, preterm milk, foremilk, and hind milk. Now the colostrum. Colostrum is the milk that is secreted from the breast in the first 2 to 3 days after delivery. It is in small amount, about 40 to 50 ml on the first day. But it is all that an infant normally needs at this time. It is rich in white cells and antibody, especially immunoglobulin A, and it contains a larger percentage of protein, minerals, fat-soluble vitamins such as vitamin A, E, and K than later milk. It is yellowish in color. It provides important immune protection. Epidermal growth factor in it helps to prepare the lining of the gut to receive the nutrients in milk. Infants receive colostrum and not other feeds at this time. Colostrum is a laxative and it helps to pass meconium and prevent jaundice. Milk starts to be produced in larger amounts between 2 and 4 days after delivery, making the breast feel full. The milk is then said to be coming. On the third day, an infant is normally taking about 300 to 400 ml of uh, milk per day. On the fifth day, it is about 500 to 800 ml. Now, the breast milk will be called transitional milk when after 7 to 14 days. Now, the mature milk. It follows the transitional milk. It is more thinner and watery, contains all essential nutrients for growth of the baby. And the preterm milk is the breast milk of a mother who delivers prematurely. It has high quantity proteins, sodium, iron, and immunoglobulins. The foremilk. The milk that is secreted at the start of feed is foremilk. It is watery, rich in proteins, sugar, vitamins, minerals, and water. It satisfies the baby's thirst. The hind milk. It comes later toward the end of a feed, rich in fat content, provides more energy, satisfies the baby's hunger. It is for optimal growth. Baby needs both fore and hind milk. Baby are allowed to empty one breast fully first. Baby receives only for milk, cry excessively. Now the storage of breast milk. Human milk can be stored at room temperature for 6 to 8 hours. And the express milk can be stored in insulated cooler bag with ice packs for 24 hours. Breast milk can be stored in the refrigerator for about 5 days at about 40 degrees Fahrenheit temperature. It can also be kept in freezer compartment of a fridge for up to 2 weeks at 0 to 5 degrees Fahrenheit. It can be stored in deep freezer for about 3 to 12 months. Now the composition of milk and its differences from the cow milk. Both both the milk contain equal amounts of water. The energy contents are equal, approximately 20 kilocalorie per kg per ounce. The protein. Cow milk contains higher protein, approximately threefold. It contains of casein is about sixfold, while the human protein is mainly whey protein that are lactalbumin or lactoglobulin, but 30% casein. Carbohydrates. Human milk 7%, which is lactose, while cow milk is carbohydrates have 4.5%. Now the fat contents. Contents are almost equal, but there is qualitative difference as both containing triglyceride, olein, palmitin, and stearin, but human milk contain twice of the more absorbable olein. Minerals. Cow milk contains much more of all the minerals except iron and copper, and although breast milk iron is low but better absorbed by its bioavailability is higher than the cow milk, and the infant will depend on the iron stores in the first 4 to 6 months. Vitamins. Both has the large amount of vitamin A. Cow milk has low vitamin C and D. Also, human milk has low vitamin D and depends largely on the maternal nutrition and sun exposure. Both milk contains adequate amount of vitamin B complex, so breastfeed infants should receive a daily requirements of vitamin D, which is 400 international unit per day. Now this is a table that is showing the composition of milk of the human milk and the cow milk. The fat content of the human milk is 3.8, while that of the cow is 3.7. The proteins in human and cow, the casein protein in humans is 0.4, while in cow it is six-fold larger, that is 2.8. While the whey proteins in human and cow milks are equal, that is 0.6. The lactose content of the human breastfeed is 7, while that of cow is 4.8. Now the preparation for the successful breastfeeding. The steps include the motivate mother before birth, select right place for the delivery, avoid unnecessary use of drugs prior to delivery, initiate breastfeeding soon after delivery, give colostrum and avoid pre-lactal feeds, help baby suckle in a good position, recommended demand feeding, continue each feed as long as baby wants, do not wash nipple before and after every feed, caution mother in advance about engorgement. Breastfeeding techniques. In a good attachment is needed for the good flow of the breast milk. For this, much of the areola and tissues underneath it, including the larger ducts, are in the baby's mouth, as shown in the figure. The breast is stretched out to form a long teat, but the nipple only forms about one-third of the teat. The baby's tongue is forward over the lower gums beneath the milk ducts. The baby is suckling from the breast, not from the nipple. This position of suckling is comfortable and often pleasurable for the mother. Now the poor attachment. Only the nipple is in the baby's mouth, not the underlying breast tissue or the ducts, as shown in the figure. The baby's tongue is back inside his or her mouth and cannot reach the ducts to press on them. Suckling with poor attachment may be uncomfortable or painful for the mother and may damage the skin of the nipple and areola, causing the sore nipples and fissures or cracks. And it may result in inefficient removal of milk and apparent low supply. Now, these are the signs of good attachment and poor attachment. The four signs of good attachment are: more of the areola is visible above the baby's top lip than below the lower lip. The baby's mouth is wide open. The baby's lower lip is curled outward. The baby's chin is touching or almost touching the breast. Now the four signs of poor attachment that are: more of the areola is visible below the baby's bottom lip than above the top lip, or the amount above and below are equal. The baby's mouth is not wide open. The baby's lower lip points forward or is turned inwards. The baby's chin is away from the breast. Effective suckling. Effective suckling needs to be well attached. The babies take slow, deep suckles followed by a visible or audible swallow about once per second. Sometimes the baby pauses for a few seconds, allowing the ducts to fill up with milk again. When the baby starts suckling again, he or she may suckle quickly a few times, stimulating milk flow, and then the slow, deep suckles begin. The baby's cheeks remain rounded during the feed. Towards the end of a feed, suckling usually slows down with fewer deep suckles and longer pauses between them. This is the time when the volume of the milk is less, but as it is fat-rich hind milk, it is important for the feed to continue. When the baby is satisfied, he or she usually releases the breast spontaneously. The nipple may look stretched out for a few seconds or two, but it is quickly returned to its resting form. Signs of ineffective suckling. Signs of ineffective suckling are when it is poorly attached or when suckle quickly all the time without swallowing. Cheeks may be drawn in as or she suckles, swallowing that milk is not falling and not flowing well into the baby's mouth. When the baby stops feeding, the nipple may stay stretched out and look squashed from side to side with a pressure line across the tip, showing that the nipple is being damaged by incorrect suction. Now the consequences of ineffective suckling. When a baby suckles ineffectively, transfer of milk from the mother to baby is inefficient. As a result, there is a poor weight gain of a baby. There may be blocked duct or mastitis in the mother. The baby may pull away from the breast out of frustration and refuse to feed. The baby may be very hungry and continue suckling for a long time or feed very often. The breast may be overstimulated by too much suckling, resulting in oversupply of milk. The causes of poor attachment are due to use of feeding bottle. When at first the baby is fed with the bottle, the baby the suckling mechanism for bottle and the breast milk are different, so it becomes very difficult for the infant to for breastfeeding. Functional difficulties such as flat and inverted nipples, a very small or weak infant, is inexperience of the mother. Breastfeeding positions. The baby's body should be straight, not be bent or twisted. The baby's head can be slightly extended at the neck, which helps his or her chin to be close in to the breast. He or she should be facing the breast. The nipple usually points slightly downwards. The baby's body should be close to the mother. His or her whole body should be supported. The baby may be supported on the bed or a pillow or the mother's lap or arm. Now the breastfeeding positions. The cradle hold. This is the most common position used by the mothers. Infant's head is supported in the elbow. The back and buttock is supported by the arm and lifted to the breast. The number second position is football hold position. The infant is placed under the arm like holding a football. Baby's body is supported with the forearm and the head is supported with the hand. Many mothers are not comfortable with this position. It is a good position after operative procedures. Now the side lying position. The mother lies on her side, propping up her head and shoulder with pillows. The infant is also lying down facing the mother. It is a good position after cesarean section. It allows the new mother some rest. Most mothers are scared of crushing the baby by this position. Now the cross cradle hold position. It is ideal for early breastfeeding. Mothers hold the baby crosswise in the crook of the arm opposite the breast. The infant is to fed. The baby's trunk and the head are supporting with the forearm and palm. The other hand is placed beneath the breast in a U shape to guide the baby's mouth to your breast. Now the advantages of breastfeeding to the child. It is a complete nutrition for a child. It contains most suitable protein and fat rich in essential fatty acids that are linoleic acid and linolenic acid. More lactose than other milk. It offers enough vitamins, iron and water that has correct proportion of salt, calcium and phosphate. It has special enzyme lipase helps in proper digestion of fat. It covers against infections. It has anti-infective factors that are immunoglobulin A, lactoferrin lysozymes, T and B lymphocytes, and antiviral factor. No advantages of breastfeeding to the mother. It is convenient, cheaper than the artificial milk, helps in expulsion of placenta and minimizes risk of postpartum hemorrhage. It is calming effect to the mother. It contour of body come back to the normal. Advantages. to both mother and child are develop a close living bond. It helps in child spacing and cost benefits. Barriers to the effective breastfeeding. The barriers to effective breastfeeding are lack of confidence in mother, believe that breast milk is not sufficient, lack of adequate support system, history of previous breast surgery, breast engorgement, freckle and sore nipple, embarrassment by mother, chronic illness in mother, data psychosis and cancer. Contraindications to breastfeeding. Contraindication to breastfeeding is when the mother is infected with HIV, if she has active tuberculosis, herpes lesions on mother's breast, infant with inborn error metabolism, that is phenylketonuria, should not be breastfeed. Mothers on certain medications that are anti-cancer therapy, radioactive isotope feeding is withheld for the period the mother is on the drug. She can express and discard the feed. Issues in breastfeeding. Issues in breastfeeding are when the nipples are inverted or flat, when the nipples are sore, when breast is engorged, or there is a breast abscess or not enough milk. Rules of breastfeeding. Exclusive breastfeeding for about 6 months and to continue for at least the second year. Complementary foods rich in iron and other micronutrients should be introduced at about 6 months of age. Mother and infant should sleep in proximity to each other to facilitate breastfeeding. Initiation of breastfeeding should be encouraged as soon as possible after birth, ideally within 1 hour. Encourage 8 to 12 feedings every 24 hours till 2 to 3 months, then 6 months till 6 months, 6 feeding till 6 months, then feeding till 1 year. At every feeding, the infant is placed only on one breast and then during the next feeding on the other one, thus alternating them. The duration of feeding is about 20 to 30 minutes. However, it is said that there is no exact time for every feeding of the infant. Every infant sucks the breast with different frequency and different duration of feedings with the day. The amount of milk that the breast produces depends partially on how much the baby suckles and how much milk he removes. More suckling makes more milk. Breast milk flow depends partially on the mother's thoughts, feelings, sensations. It is important to keep mothers and babies together day and night and to help mothers to feed good about breastfeeding. Give no supplements, water, glucose water, commercial infant formula, other fluids to breastfeeding newborn infants. Specify should be offered while placing infant in back to sleep position no earlier than 3 to 4 weeks of age and after breastfeeding has been established. All breastfeeding infants should be seen by the pediatrician at 3 to 5 days of age to evaluate hydration, evaluate body weight, assess the feeding and consider more frequent follow-ups, discuss maternal infant issues and observe feeding. All breastfeeding should receive 400 international units of oral vitamin D drops daily beginning during the first 2 months of life. Do not forget to administration of intramuscular vitamin K until after the first feeding is completed, but within 6 hours of birth. Now the third portion of the presentation is kangaroo mother care. Kangaroo care is a method of holding your body to your chest. This allows for skin-to-skin contact between you and baby. During each session, your baby will be placed naked except for a diaper and hat on your chest. Also bear to allow skin-to-skin for up to few hours. A blanket shirt or hospital gown or rope can be wrapped around you and over your baby's back for warmth. This wrapping of your infant into your chest looks very much like a mother kangaroo holding her baby in her pouch, which is where the name kangaroo care comes from. Kangaroo mother care is recommended for the routine care of newborns weighing 2,000 grams or less at birth and should be initiated in healthcare facilities as soon as the newborns are clinically stable. Newborns weighing 2,000 grams or less at birth should be provided as close to continuous kangaroo mother care as possible. Intermittent kangaroo mother care rather than conventional care is recommended for newborns weighing 2,000 grams or less at birth if continuous kangaroo mother care is not possible. Conventional neonatal care of low birth weight infants is expensive and needs both highly skilled personnel and permanent logistic support. Evidence suggests that kangaroo mother care is safe and effective alternative to conventional neonatal care, especially in under-resourced settings, and may be reduce morbidity and mortality in low birth infants, as well as increase breastfeeding. Kangaroo mother care involves early, continuous, and prolonged skin-to-skin contact between a mother and her newborn, frequent and exclusive breastfeeding, early discharge from the hospital. The benefits of kangaroo mother care to the baby are stabilizing the baby's heart rate, improving your baby's breathing pattern, and making the breathing more regular, improving oxygen saturation levels, gaining in sleep time, experiencing more rapid weight gain, decreasing cry, having more successful breastfeeding episodes, having an earlier hospital discharge. Now, the benefits of kangaroo mother care for parents are the benefits of kangaroo can include improving bonding with your baby and the feeling of closeness, increasing your breast milk supply, increasing your confidence in the ability to care for your new baby, increasing your confidence that your baby is well cared for, increasing your sense of control. Now, the recent update on the breastfeeding. The article published is with the title is Effectiveness of Integrated Breastfeeding Education Program to improve self-efficacy and exclusive breastfeeding rate, a single-blind randomized control study. The background is that low self-efficacy affects new mothers' ability to sustain breastfeeding. Intervention that increase self-efficacy could improve sustained breastfeeding. The objectives of this article is to develop an integrated breastfeeding education program based on self-efficacy theory and evaluate the effect of intervention on first-time mothers' breastfeeding self-efficacy and attitudes. The methods. A three-week breastfeeding intervention program was developed based on self-efficacy theory. The intervention group received the breastfeeding program. The control group received the standard care. Data between groups were compared for source of breastfeeding self-efficacy, infant feeding attitude, and breastfeeding practice, which were assessed using the breastfeeding self-efficacy scale. Repeated data measurements were collected at baselines of 36-week gestation and postmortem at 1 week and 1 to 3 and 6 months. The conclusions of this article is that the breastfeeding education intervention improved the breastfeeding self-efficacy, infant feeding attitudes, and exclusive breastfeeding rates. The breastfeeding education program could be effective for sustaining breastfeeding in new mothers. Now the session of the MCQs. The first MCQ is when the baby is placed in skin to skin on mother at birth, what behavior should he demonstrate instinctively before latching? Option A is moving to the breast and touching the mother's body and breast. B option is slowly going into deep sleep, then starting to move hands and feet, crying vigorously and then resting without movement. D option is slowly calming down so a helper can assist the baby to reach the breast. Which is the correct
A.
option?
B.
Option A is the correct option, that is moving to the breast and touching the mother's body and breast. Second MCQ is why is suckling at the breast important in the first 2 hours when the baby is ready? Option A is sucking triggers normal onset of milk production. B option is infant is fed, so glycemia or blood sugar is normal. C option mother can safely rest after first suckling. Option D prevents infant dehydration.
A. B.
Option A is correct
A.
as if the breastfeeding initiated within the first 1 or 2 hour, it triggers the normal onset of milk production. Third MCQ is which statement about exclusive breastfeeding is correct? Baby will get all the nutrients needed by the effective exclusive breastfeeding. Mothers do not have enough breast milk in the first few days. Some supplementation with artificial milk won't alter the intestinal microflora. Option D is mother needs to exclusively breastfeed every 3 to 4 hours to have enough milk.
A.
A.
Yes,
And first,
option A is the correct answer. Fourth MCQ is what information would you share with the mother about a normal baby's typical feeding patterns in the first 36 hours of life? Option is feeding patterns are determined by the mother so that the infant is correctly trained to a feeding schedule. Option B is minimum feeding frequency is 8 to 10 times per 24 hours. Mother could only feed baby 6 times per day. Cluster feeding indicates no milk transfer and baby necessitates supplementation.
A.
B. B. B.